Hello everyone. My name is Dr. Jan Christelaw and I'm an obstetrician gynecologist from Vancouver, Canada. And I'm here today on behalf of the Canadian Network for International Surgery. I'm here today to talk to you about the complications and post-operative care following caesarean section. As caesarean section is one of the most common operations done in the world today, this is a very, very important topic to cover. So now we're going to think a little bit about the factors that contribute to postoperative infections in caesarean sections. And I'd like to think of it in terms of the most common sites where we see those infections. And that would be wound, bladder, and endomyometritis, or the lining of the uterus. One of the things to remember is that once the membranes are ruptured during labor or childbirth, ascending infection is possible because the vagina is actually full of bacteria. And even if they are healthy bacteria, as they ascend into the abdominal cavity, into the uterine cavity, they can cause infection because that cavity is really meant to be sterile. The infections that are caused by the ascending bacteria from the vagina can either be chorioamnionitis, that is an infection of the amniotic fluid and the chorion membranes, and that would be during labor and delivery, or an endomyometritis if the infection actually affects the lining of the uterus, which is usually after the birth of the baby. Now, as you can see, the anatomy itself presents the possibility of ascending infection just because of the way the vagina is connected to the uterine cavity. But let's look at a bit closer at some of the issues that can contribute to the infection rate and infection itself in the abdominal incision. Well, you have to look really at the fact that the factors are really similar to those involved in urinary tract infections. When you think of it, there are some similarities. When you put the catheter in the bladder, for example, you actually give the bacteria a conduit from going from the exterior part of the urethra up into the bladder. You can also actually have an infection that's present before surgery, and of course this can be made worse by the presence of the catheter. Now, the other thing is that because the bladder can be relatively obstructed during labor and delivery by the big head or by the labor itself, there tends to be stasis of the urine in the bladder during labor. And this is another factor leading to infection. Now, you may have a simple wound infection or a simple bladder infection, and we can treat those. We're good at treating those. What we want to avoid, however, is the infectious complications that are more difficult to treat. Abscess formation is one of these. If you have an abscess form in the abdominal wall after a caesarean section, it may well take you back to the operating room, and it may actually significantly delay the healing after a caesarean section. And an abscess can happen de novo if there's infected fluid in the incision, but it's more likely to result from a hematoma that becomes infected. This is one of the reasons why we really insist on very, very good hemostasis. You don't want any seeping vessels, especially in the abdominal wall after a caesarean section. Any collection of blood is at high risk of becoming an abscess if it becomes infected. The other thing we see more rarely after caesarean section is the intra-abdominal abscess. And this can actually be very, very difficult to diagnose. I would say that one of the most difficult cases I ever had was a subphrenic abscess, which was almost impossible to see on ultrasound or any other way. And we found it only when we went back to the OR for a persistently febrile patient who was not doing well. And there are many, many other examples of places that abscesses can hide within the intra-abdominal cavity. So that's a little bit about infection, but we have to remember what is the #1 cause of maternal mortality worldwide. You've heard about this already over the last few days, and you know very well the answer to this question. That is hemorrhage. More women die of hemorrhage than die of any other cause. Although sepsis is a close second now, and it's actually gaining on hemorrhage as a major cause of death. Why hemorrhage? Well, first of all, the pregnant uterus is extremely vascular. So at the time of cesarean section, the blood loss can be significant. Certainly, significant operative bleeding may arise from the cut uterine edge, and that's especially true if closure is delayed. So the best way of controlling hemorrhage is to get the uterine incision closed as soon as possible. And of course, this can be more difficult if there are extensions or if there are tears that go into the sidewall or any other part of the anatomy of the pelvis. Now, late uterine bleeding after cesarean section can be caused by any one of the causes of postpartum hemorrhage. And if I was doing this interactively with you, and I would now have you tell me exactly what those causes are. So we've talked a little bit about infection and postpartum hemorrhage, or hemorrhage generally, including surgical hemorrhage. But there are some other serious complications associated with cesarean section that arise. And these often arise from the indication for the cesarean section. So for example, if you have an abruption, one of the things that can happen, and I'm sure you've seen this, is a cuvalier uterus, where the myometrium itself becomes heavily hemorrhagic and unresponsive to tonic medications. The other thing, of course, we see, especially if we're doing a vaginal birth after cesarean section, is ruptured uterus. But remember, we do see ruptured uteruses at other times as well, especially in the long obstructed or neglected obstructed labor. So always keep these things in mind. I just wanted to say a few words about septic shock. Usually if you have a patient that's truly in septic shock, it results from an infection that was probably brewing prior to delivery. In other words, you start with a patient that's already slightly compromised, but of course this is not always the case. If you have a wound infection or anything that happens at the time of cesarean section, it can also lead eventually to septic shock. The patient in septic shock is in mortal danger and is an absolute emergency and requires a full team mobilization in order to save her life. It requires systemic stabilization, aggressive use of antibiotics, and the treatment of the underlying cause, whether that's an abscess, whether it's a generalized infection, or whether there's another focal cause for the septic condition in which you find yourself. I wanted to say a few words about thromboembolism. Now, blood clots are a common cause of maternal morbidity and mortality in North America. In fact, they are virtually as common as deaths related to postpartum hemorrhage in Canada. But of course, in most of the world, they are well behind bleeding infection, but don't forget about them. If a woman does have a thromboembolism, especially if she develops a pulmonary thromboembolism, it can be a life-altering or life-threatening complication. So please always keep it in mind. The diagnosis may often be made clinically, and the prompt treatment with heparin or other anticoagulants can be life-saving, but you don't have a lot of time, and you will have to react quickly as soon as the suspicion arises. Amniotic fluid embolism. This is on the list always, and it's reported as a rare complication. But I need to tell you that I've seen 2 women with this very, very serious condition myself in my own practice. One of them we were lucky to save, and the other, which happened in my hospital about 5 years ago, we did not. We had a woman die of an amniotic fluid embolus about 5 years ago. What happens at the time of an amniotic fluid embolus is that the fluid itself enters the maternal vascular system and moves to the lung. Amniotic fluid, as you know, is not a simple fluid. It's a fluid that's full of things like potentially meconium, vernix, other things that actually make it so that there's all bits of particulate matter in it. It's not so much the fluid itself as the matter that's in the fluid that can get stuck in the vessel, the maternal vessels, and can lead to the effect of a fluid embolus. It probably is related to the sudden contraction of the uterus with the fluid pushed out of the uterine vessels under severe pressure. Now, in the fully blown form, the case fatality rate can reach 60%. That's very high, and of course it means that this is a very much a life-threatening situation. Let's talk a little bit more about complications of caesarean section more generally, and think about how we classify them. It's not the most straightforward thing to do. Sometimes we think about them as major versus minor, and of course this is a continuum. It's not black and white. Sometimes we talk about immediate versus delayed, and this is often really helpful because we know that the most severe of complications will happen in the first hour or 2 after delivery. Those are the immediate. And so we feel confident if a patient's relatively stable, that it's safe to send her to the ward after that time. But we can't forget about the delayed complications, which of course can include hemorrhage, infection, or all the other things that we've talked about today. And of course, the other way to look at it is an intraoperative complication as opposed to one that happens after the operation is finished. Now, I want to talk a little bit about how we classify risk in terms of how often it happens. We as humans are not very good at understanding this concept. So for example, if you hear that something happens rarely and you hear that it happens 1 in 10,000 people, it may still be more worrisome to some people, especially to patients, than something that might be much, much more common. I find that the system that is most useful is to actually always talk about the actual numbers. So instead of talking about something as a rare complication, cite the number from the literature. So for example, the risk of rupture in vaginal birth after caesarean section is roughly 2 per 1,000. Or the risk of pulmonary embolus after caesarean section is 1 in 2,000. Now that gives you a sense, and should, even when you're talking to your patients and getting informed consent, give the patients more of a more concrete concept to think about. I'm very fond of the National Institute for Health and Clinical Excellence from the UK. In fact, you've seen some of my other slides and presentations from their work even earlier this week. I love the way they simplify this, so it makes it very, very clear. If, for example, you say something is very common, it means that it happens more than 1 in 10 times. Common, 1 to 10 times out of 100. Uncommon, 1 to 10 times out of 1,000. Rare, 1 to 10 out of 10,000. And very rare, 1 to 10 times out of 100,000. So you see, with each category, you're actually increasing by an order of 10. And this makes it much clearer when we're discussing with patients what the relative risks are of all complications. We could talk about this for hours, but for now I'm just going to summarize briefly. I would start by saying you need to be prepared for the possibility of complications and know how to treat them before you embark on any surgical operation. But that's especially true of cesarean section because you're treating both the mom and the baby, and you have to think about the mom and the baby and the whole family. This is part of the reason where we always say never intervene unnecessarily. A cesarean section may seem like a simple thing to do, and it's an operation we do commonly, but there is always the risk for complications. We have to keep that in mind, and we have to keep the safety of our patients always at the center of the picture and make sure that we never intervene unnecessarily and subject them to the possible complications of this or any other operation. We also have to continue to strive to achieve excellent surgical technique in order to lower the risk of complications. If you really think about it, one of the best things you can do for your patients is make sure that your knots are secure. Make sure that your knots at either end of any incision are tight, that they're square, that they're not going to slip, and that there's no leakage at those points. That the bleeders that you've tied off have been done so securely, and that you have achieved excellent hemostasis before you leave the surgical field. That, more than anything else you're going to do, is going to lower the risk of post-op infection, post-op hemorrhage, and then further resultant complications such as abscess and other intra-abdominal bleeding, just as examples. The immediate postoperative period, as we've already said, is when most of the serious and acute complications occur. But that doesn't mean that you can ignore your patient once she goes back to the ward. It's very, very important that you keep a very close eye on how things are going and make sure that things are going the way you expect. Just a few words about care immediately following surgery and operative delivery. Please always write well-organized orders that include the following things: vital signs, diet, activity, the IV fluid that you're giving her, the type, rate, and duration, that you monitor urine output until a catheter comes out to make sure that it's adequate. Order the investigations that you want, for example, any lab investigations you want either immediately post-operatively or the next day, and any medications that you're going to use, including antibiotics and analgesics. Everybody has their own way of thinking about this, and so the order that these things are in is not important, but it is important that you always remember. So having a mnemonic that makes some sense to you is always a good idea. One of the things I think that we have learned at my hospital is that when there are complications, they're almost always the result of teamwork and communication falling short. So it's very important that you work as a team and that all members of your care team know exactly what the plan is for the patient. And it's also very important that you carefully watch vital signs, vaginal bleeding, urine output, and that's true whether or not it's an assisted vaginal delivery or a cesarean section. Care immediately after either of these is very, very important, and it's important that the whole team know what you're worried about in terms of possible complications. We do use antibiotics, as you know, much more than we did 10 years ago, and we certainly use them as available if there's any signs of infection. And using them prophylactically is a very good concept as well. I think it's important to remember that sufficient pain medication to keep the mom comfortable is a very, very important part of care, and that it's easier to prevent the pain from coming back, in other words, to give her regular medication, than it is to treat the pain once it becomes acute. It's also important that we not allow patients to become dehydrated post-operatively or at post-vaginal delivery. So we continue IV fluids until they are drinking well. But we do want people to get up as soon as possible. There are several reasons for this. First of all, we know that it's just better in terms of healing. We know that it helps prevent thromboembolic complications. We know that it prevents infection. And we know that the sooner that we get that catheter out of the bladder, the lower the chance of a uterine tract infection. Oral fluid should be started right on the day of surgery or the day after surgery, or as soon as tolerated. So obviously, if somebody is vomiting a lot, you might hold off for a little while, but if they're not, then start them as soon as they can tolerate them. Just want to end by saying post-operative care is patient-centered care. You're not treating one symptom. You're not even really treating one patient. You're thinking about the whole patient and what is best for her and her baby. And that includes things like her ability to breastfeed, her ability to look after her baby, and the ability of the family to really enjoy the new addition to their family as much as possible. And this is how you should think about your charge right from the moment they walk in the door until the moment they walk home. Please always keep your patient at the center of your consciousness and make sure that your first thought is always for your patient and their safety.